Hello, so I'm doing my essay prompt number one for cardiovascular physiology. I first off wanted to start by saying, sorry about my voice. I have been sick for a little bit, and I'm gonna try to do my best, but please bear with me with it. And so the first prompt we're gonna talk about all the steps of depolarization and muscle contraction within the heart, and then also include HFrEF and HFpEF heart failure and different modalities that you can use to diagnose and help visualize the pathology of HFpEF and HFrEF. So first thing I was going to start with was going to be the myocardial cell, and on the inside of the cell it's going to be negative 70 millivolts. And in order for a depolarization to happen, sodium has to rush into the cell to get it to a threshold. And so we can visualize that on a graph where you have negative 70 millivolts. And then as soon as sodium starts to rush in, sodium's going to trickle in first, and then it's going to hit a mini threshold at around negative 55 millivolts, where sodium is then going to rush in, causing a depolarization. And then as soon as it reaches the action potential, the sodium channels are going to turn off, and potassium channels are going to open, with potassium leaving the cell, repolarizing the cell. Where it's actually going to go and dip below where the negative 70 millivolts is to hyperpolarize during the refractory period, basically so that another contraction, another depolarization cannot occur immediately following. It needs to have a little period of refractory. And then sodium potassium pump reestablishes the gradient at around the negative 70 millivolts for another depolarization to happen. The sodium potassium pump, it pumps two sodiums out, or three sodiums out, two potassiums in. And so from here we can then go to the conduction system throughout the heart. The heart's a little potato, and it's divided into four chambers. You have the right atrium, right ventricle, left atrium, left ventricle. And so this electrical activity up here is monitored by the SA node in the right atrium that spontaneously depolarizes at a rate of about 100 beats per minute. And whenever it spontaneously depolarizes, it it sends the depolarization signal to other myocardial sites through intercalated discs, and I'll kind of show later on how it does so. But it depolarizes, and it sends that signal to other myocardial muscle cells to cause contraction in the atria to flow into the ventricles. And whenever that signal hits the AV node, it delays that signal to allow the contraction in the atria to occur, allow full contraction and full ventricular filling. The AV node, after it delays the signal, then sends the signal to the bundle of His, down to the bundle branches, and then finally to the Purkinje fibers, which then send that signal up and cause contraction of the ventricles in an upward manner through the valves to go to the pulmonary artery, and then the aortic, or the aorta. And so that's the electrical conduction of the heart. And then here's another way we can look about. Oops, sorry. So right here is that intercalated disc. And this is what I was talking about before. It helps pass that signal cell to cell. The electricity flows through the intercalated disc to the next cell, where it can flow along the sarcolemma, and it will cause the sodium influx of the cell to cause that depolarization. Goes down the sarcoplasmic or the T-tubule, where these little calcium sensing feet, these L-type calcium channels, will sense that sodium, and sense that electricity, sense that conduction, and it'll send the signal to the sarcoplasmic reticulum, where these ryanodine receptors will then release calcium from the sarcoplasmic reticulum that will then go to the my the myofibrils, and it will cause muscular contraction and increased contractility. And so if we go look at the sliding filament mechanism, you have T and T, T and C, and T and I. The calcium will bind to the T and C, which will move TNT off of the tropomyosin. So this whole filament right here is troponin, and this is tropomyosin that is covering the actin. And by binding calcium to TNC, moving TNT, which then moves tropomyosin, the actin will be available for myosin heads to go and latch on to the actin, and once it latches onto the actin, in order for the contraction to happen, ADP needs to drop off, and then inorganic phosphate drop off. Each one's 50% of the contraction. Once the contraction fully occurs, once both those things are dropped off, it's fully contracted. In order to release the myosin head, ATP needs to bind and hydrolyze in order to release that, and that will recock, reload, and reset the contraction, and that's how force is generated in these in this actin myosin cross bridge formation. And so that's the general idea of electrical conduction, contraction of the heart, how impulses and contractions sent throughout. And so we can go and talk about heart failure and how that relates. So you have two types of heart failure. You have HFrEF, which is basically, it's heart failure with reduced ejection fraction. And then HFrEF is usually due to systolic functions. Systolic dysfunction, my apologies. So it's whenever you have trouble doing the actual contraction part. Systolic just means contraction, so you're having trouble with the contraction and getting the heart out of the blood, or my bad, getting blood out of the heart. Basically your heart will be weak, you can't pump blood effectively, you won't be able to get blood out of the heart, get oxygen that's in the blood to the systemic circuit, and that can possibly cause hypoxic tissue, even possible tissue death if you can't get enough blood, enough oxygen to the peripheral tissues. And it can often be caused by previous myocardial infarctions or dilated cardiomyopathy. And so the other type of heart failure is HFpEF, which is preserved ejection fraction. And instead of systolic, it is diastolic dysfunction. And it's whenever the heart is stiff, it doesn't have the same stretch that it normally does, and it doesn't fill well, so that's where the diastolic comes in. Diastolic is whenever it's not contracting, and normally the ventricles get around 70% of their blood from passive filling. So if the heart is not able to stretch as much, it's not able to fill as much, you won't be able to get as much blood, and so you won't be able to then fill the heart as much and get more oxygen, more blood to the heart. And it's usually caused and linked to conditions like hypertension, obesity, as well as aging. And then some different ways we can actually, some different visual modalities that we can do to visualize this is, the first one is echocardiogram. And the reason why we would use echocardiogram is to evaluate structure and function. It's non-invasive, which is huge. As well as it's pretty accessible. And it will be able to show the ejection fraction. So whether it's HFpEF or HFrEF, whether we have a low or normal ejection fraction. And so if we have a low, it'll show HFrEF. If we have just a normal or a relatively higher, it'll be HFpEF. It'll also be able to indicate ischemic/infarction. As well as ventricular size and wall thickness. So it'll be able to determine if the ventricle is dilated, like it is in HFrEF, or if it's hypertrophied and stiff, like in HFpEF. And overall, the echo is very good for differentiating between systolic and diastolic heart failure, and it's a good way to visualize and determine it. The next modality is MRI, and it's a good quality for detailed anatomy and myocardial tissue analysis. It's also uses no radiation, so it would also be a very good one to use to determine and gather information regarding heart failure and different things affecting the heart. It'll be able to show ejection fraction and volumes, reveal scar tissue of previous myocardial infarctions. My apologies. An overall MRI would be able to give us structural and tissue level information and help distinguish the disease that they have. Okay, the next modality is a PET scan. This one does use radiation, so that would be one of the few possible things to look out for. And it would actually evaluate myocardial perfusion. To detect ischemia and that would be likely a cause of HFrEF. And so the nuclear scan, PET scan, would help determine if the poor heart function is due to the dead perfusion, like the low perfusion tissue, or if the tissue is normal perfusion, and we would be able to then determine and go from there. And finally, we have a CT scan. My apologies. And it's good for assessing coronary artery disease. And you can also use an echo with the CT scan to get more information about the patient if you want to do a deeper dive. And this would be useful in determining ischemic heart disease as well as underlying cause of heart failure. Because if you're looking at, if it's been able to tell you if you have coronary artery disease, that would be able to determine what kind of heart failure they have, as well as be able to find a possible diagnosis for it and a possible treatment for it. But overall, that is my presentation about heart failure, as well as the conduction system of the heart and stuff like that. So sorry for my voice. I know it's not the best, but thank you so much.